Introduction to Stroke, Pathophysiology and Common Impairments. Stroke is the third leading cause of death worldwide and a leading cause of disability worldwide. In the United States alone, over $60 billion is spent on care following stroke. A recent publication in the Ghana Medical Journal in 2014 reports that nearly 2/3 of all stroke fatalities occur in resource-limited countries lacking infrastructure and support. In the United States, following a stroke, we know that 13% of people will die within 30 days, 24% will die in 1 year, 14% will have another stroke within 1 year, and 50% will die within 5 years. Detecting a stroke and getting someone proper medical care is the best way to help them preserve their function and life. There are 4 things you want to look at in order to detect a stroke. Face. Ask someone to smile. Does one side of their face drop to the side? Arms. Ask the person to raise both arms. Are they able to do that? Speech. Ask the person to repeat a simple sentence. Are the words slurred, or can they repeat the sentence correctly? And most importantly, time. If the person shows any of those symptoms, get them to the hospital as fast as you can. Time loss is brain loss. So what is a stroke? A cerebrovascular accident or stroke is a clinical diagnosis defined as brain, spinal cord, or retinal cell death as a result of inadequate blood supply. A stroke will have resulting impairments lasting more than 24 hours. Their symptoms will be focal, sudden, and maximal in onset. A transient ischemic attack, or TIA, or mini stroke, is an episode of neurologic dysfunction similar to a stroke where the symptoms last less than 24 hours. Up to 40% of individuals with a TIA will have a stroke, and the majority of those will occur within 30 days of the original TIA. There are 2 types of stroke: ischemic, resulting from a blood clot, which is 85% of strokes, and hemorrhagic, which is resulting from a bleed and is typically 15% of strokes. An ischemic stroke can either be a clot that is formed in an artery or vein, or embolic, meaning a clot traveled from the heart or a larger artery and lodges itself in the brain. Hemorrhagic strokes can either be a result of an intercerebral hemorrhage, or bleeding within the substance of the brain, or a subarachnoid hemorrhage, which is bleeding around the brain. There are a number of common physical impairments that result from stroke. We'll discuss 3 of them here today and expound upon those as we work together. The first is hemiparesis, or unilateral weakness. The second is flaccidity, or complete lack of muscle tone or contraction. And the third is spasticity, or increased muscle tone. Hemiparesis is the most common impairment following stroke. It's defined as unilateral weakness related to upper motor neuron damage. The degree of weakness varies widely among different patients and diagnoses. 80% of acute and 50% of chronic physical therapy referrals are related to hemiparesis. Hemiparesis most commonly presents on the contralateral side of the lesion or the opposite side of the lesion, but it can also be ipsilateral or bilateral depending on the area affected. The initial grade of hemiparesis based on strength testing can be an indicator of function down the road. For example, we know that if somebody has minimal hip flexion and is unable to sit independently after a stroke, they will be unlikely to walk independently in the future. Recovery of the upper extremity, lower extremity, and trunk will usually occur at the same rate. Flaccidity, or lack of muscle tone and strength, is usually present in the first month following stroke. There's typically no isolated or voluntary movement in the extremity. It can be present in all of the limb or only a portion of the limb, and can be present in the upper or lower extremity. When someone has chronic flaccidity following a stroke, limb management is very important. You want to make sure to protect the limb from injury, avoid subluxation or dislocation, possibly using a sling. Direct the patient's attention to their flaccid limb so they don't accidentally injure it. Weight bear as much as you possibly can, and check the skin. Spasticity is defined as velocity-dependent resistance to passive stretch. This means that if you try to move the limb through its range of motion quickly, you will get a catch or an inability to move it further. If you move the limb slowly, you will be able to move it through its full range of motion. Spasticity is usually evident 1 to 3 months following stroke and is more common in the upper extremity muscles compared to the lower extremity muscles. The two pictures below are common patterns of spasticity that you can see following stroke. The first is an equinovarus foot posture, which can result of spasticity in the ankle plantar flexors or your calf muscles. The second is an upper extremity flexed posture that can result from spasticity in the elbow flexors or biceps, as well as the wrist and finger flexors. Although the presentation of stroke varies widely amongst different patients, there are some comical clinical presentations that we see depending on which arteries are affected. Today, we're going to discuss the 3 most common presentations, which are the middle cerebral artery, the anterior cerebral artery, and the posterior cerebral artery. Depending on which one of those is affected, there will be very different but also very predictable impairments in your patients. A middle cerebral artery presentation typically includes contralateral weakness, usually with arm more affected than leg, contralateral sensory loss, again with arm more affected than leg. There's also typically a motor speech disorder called aphasia. There are 2 types of aphasia that are typically present. The first is Broca's aphasia, where someone is able to understand speech, but they cannot generate any fluent speech. They may be able to say 1 to 2 words, and speech will be difficult. Wernicke's aphasia indicates that the patient is unable to understand, but able to generate speech. Usually their speech is nonsensical and hard to understand. They will also experience perceptual deficits, such as neglect, which is an inability to attend to one side, difficulty with depth perception, spatial relations, and agnosia. Finally, they will often experience contralateral homonymous hemianopsia, which is loss of sight on the same side of both eyes. An anterior cerebral artery presentation typically includes, again, contralateral hemiparesis, this time with leg more affected than arm, contralateral sensory loss, and typically some frontal lobe involvement, which can result in confusion, perseveration or repetition of words, abulia, and apraxia. These patients can also experience urinary incontinence. A posterior cerebral artery presentation will result in primarily visual and sensory impairments. In the peripheral territory, you can see contralateral homonymous hemianopsia, prosopagnosia or difficulty naming familiar people, and alexia without agraphia, which is difficulty understanding written words. In the central territory, which involves the midbrain and thalamic structures, you can see thalamic syndrome, such as involvement of the sensory and pain receptors, involuntary movements, Weber's syndrome, which is an ipsilateral ocular nerve palsy and a contralateral hemiparesis, or injury to the supranuclear fibers to cranial nerve 3, resulting in vertical eye movement paresis. When working with patients following stroke and skilled therapy, there are 2 different strategies that we can use. The first is a compensation strategy. A compensation strategy is used when the area of concern is unlikely to return to its prior level of function or initially presents with little to no active use. This is common in recovering function or looking at the upper extremity. If someone's upper extremity is initially flaccid, we may choose to use bracing or a sling in order to keep the limb protected, as we don't expect any function to return. A recovery strategy is used when the area of concern is expected to experience some recovery of previous abilities. There may be some available strength or active range of motion when you initially look at the patient. For this strategy, we use functional training, strengthening, and other re-education strategies to help the person accomplish tasks as efficiently as possible while encouraging use of their affected limb. Remember that different areas of the body may require different strategies. Your left arm may be completely flaccid and require a sling, but we may also be able to use recovery strategies in order for your left leg to help you to walk. This is a common decision-making tree based on the initial impairments that we see when we evaluate somebody who's had a stroke. As you can see, depending on the amount of tone or spasticity or flaccidity, the amount of strength, and the amount of active range of motion that a patient has available to them, we may use different techniques or have different considerations in treating them in skilled therapy. So can we recover from a stroke? The ability to recover among stroke survivors is varied and based on a number of factors. The initial severity of a stroke and time prior to medical treatment. A more severe stroke and a person who may have taken more time to get to the hospital is less likely to experience recovery than somebody who had a smaller scale stroke and was immediately treated. As we discussed earlier, the initial level of impairment based on strength and range of motion ratings is a strong indicator of someone's ability to walk or perform other functional activities independently. Some patients have comorbidities prior to having their stroke that are still apparent after the stroke. This can include obesity, older age, or prior orthopedic impairments that may make mobility difficult. Access to therapy is another issue that we face when treating patients with stroke. If a patient has had a stroke but they aren't able to access physical therapy or occupational therapy, we may see a difference in their ability to function. And finally, cognition. Someone's ability to understand what they're trying to do or ability to participate in the world around them based on their cognitive status can have a strong impact in their ability to recover. It's important to remember that many folks who've had a stroke will not fully recover. Many folks who've had a stroke may never look the same or move exactly the same. But as physical therapists, it's our job to help them move more efficiently and more safely so they might be able to spend more time in their community and with their families. Beyond the specific impairments that we've already discussed following a stroke, there are a number of functional problems that these patients experienced. The first and foremost is falls and risk of falls. We know that falls are a leading cause of death in the geriatric population and can result in injury and disability. Following a stroke, the risk of falls is significantly increased. In the United States, 72% of people reported falling within 1 year of their stroke, and risk of hip fracture is 2 times higher in people with stroke than without. Secondly, mobility. A person's ability to roll over in bed, stand up from a chair, or move safely about their home can be affected following a stroke. Many of these patients will need help with these types of activities, which can put an increased burden on their loved ones or cause their loved ones to injure themselves while helping them move. And finally, activities of daily living. Many of these patients can lose their ability to eat, dress, bathe, or wash themselves independently, again causing an increased burden to their family members. As physical therapists, we are experts in teaching the body how to move more efficiently and safely to improve our patients' quality of life. We do this through a variety of interventions, including task-specific training or teaching our patients how to perform daily tasks that are meaningful to them, strengthening of weak muscles, balance training to prevent falls and gait training to help them walk, fitness activity to improve endurance, and education. We provide education to patients and their families on expectations following stroke, safe activities to perform, and safety in the home. Hopefully, this introduction today gave you a better understanding of the physiology behind stroke, some common impairments and presentations, and a small introduction to treatment strategies. More information on the interventions we mentioned will be coming soon. Thank you so much for your time.